Oh, firstly, welcome to everyone who's joined this webinar. It's fantastic that there's so much interest in this really important area. Whilst people are finishing joining, I'm going to run through the housekeeping on the slide. As you can see, you're muted, but there is the opportunity to engage by using the chat function in the question and answers. And we're keen to answer as many of your questions as possible. So do put them in the box. If you see a question that you want to ask as well, give that question a like, a thumbs up, so we can get a better sense of the areas that you want further information on. We'll be recording this webinar, so if your connection drops off, you can come back and look at the webinar, and the link will be on the Futures website in a few days. If you'd like to be informed of the future events, there's a link for you to contact us. And also for clarification, we're not providing CPD certificates for attendance. Now, before I get on to the three presentations, we thought it'd be helpful to ask you a few questions using Mentimeter. So we're going to get a new slide. Yes, if you haven't used Mentimeter before, you need to be connected to the internet via, for instance, your phone or laptop. And all you have to do is type in www.mentimeter.com and then enter the code. Alternatively, you can scan the QR code. And then when you're in and you put in the code, you'll automatically see the questions. We're going to give you a few seconds to be able to log into that. Don't panic if you can't, but it'd be really good if you can. Okay, I'm hoping that people are finding that this is working well for them and they can get in. All right, I think we probably allowed enough time for that. So shall we start Mentimeter now? So here is the question. In your local area, so we're really talking about your situation, is there a specific offer for older people with complex emotional needs with the adapted interventions to meet the clinical need? So you've got a yes, a no, don't know, and a no. It's interesting. Obviously, lots of people are answering. This is fantastic. Very good. It's looking about, we've got about 5 seconds or so before we close. Looking at that, most are the no or don't know, and then we've got a few yes. Okay, so you can see the voting's closed. 22% yes, 36% don't know. So hopefully you'll be inspired to find out after this webinar, and 42% are a definite no. That's helpful. Can we move on to the next question, please? Have even more people filling this one in. So, can team members who are seeing older adults access the full range of HE-funded psychological therapy courses for complex emotional needs? So the answers are yes, you can have as many places as you want. Yes, but there are only a few places. Or no, we aren't even aware of it. Or no, we're not able to access it. Or finally, I've no idea, don't know. I mean, it's important because obviously we want older adults to have a great experience from therapy, and it's important that we actually know about the therapies. Okay, we've only got about another 5 seconds and then the voting will close. Slightly disappointingly at the moment that there aren't a lot of yeses. Maybe if we look at the yeses, with maybe 20% is either going to be a yes, as many places as you want, or yes, but only minimal places. So clearly there is something here that we really need to make sure that we address and that people do get the training that they need. Right, the final question, I'm expecting the most responses for this one, is have older adult experts by experience had input into your local service design for whatever your complex emotional need service pathway, whatever you call it? Have you have you engaged older adults, experts by experience, in the development of this service? I think it's really, this is a hugely important question, because how can we deliver a service if we aren't co-producing it with the people who are going to be using it? So we've got the times ticking here. I think that, and there are lots of don't knows. Again, I think this has probably raised something about actually going back and finding out, because, you know, co-production is so important. It's not us telling people what they need, it's them telling us what they need so that we can make sure we can reach it. So we've only got a very small percent of 16% have actually involved older adults. Okay, so thank you very much for everybody who very kindly filled that in. So before the presentations begin, I want to take the opportunity to very briefly run through the agenda for this webinar. We'll start with Jeff Hayes, Senior Programme Manager on the Adult Mental Health team at NHS ENI, who will outline the national context for the community mental health transformation. Then we'll move seamlessly on to Dr. Natasha Lord and then Dr. Catherine Dykes, who will between them explain how they went about scoping what the complex emotional needs of their local older adult population were, and then what specific factors needed to be considered to ensure that services can meet these needs. And that's the whole point. We want to meet the needs of older adults. The document that Dr. Dykes will refer to is available on the Futures webpage, and a link will be put in the chat. We'll then finish by answering a few of your questions. As there are likely to be more questions than time, we will look at the questions afterwards and write a response to them to go along with the webinar when it goes on the Futures website. So now I'm going to hand over to Jeff.
Thanks very much, Amanda, and good afternoon to everyone. I'm really happy to be here and part of this event today, and it's really pleasing to see so many attendees. And I think certainly from my perspective, and I think from all of you, there's definitely an area where there's a lot for us to learn and a lot for us to do differently. So I'm particularly looking forward to the conversation today and the other presentations about how we can improve this our offering to people who have these needs in our communities. So I'm gonna present on the overview of the national policy perspective around complex emotional needs, or people who may have a diagnosis or fit the diagnosis of personality disorder, and talk about how it fits in with our wider community transformation programme. And then some of our colleagues on the call will talk with more specifics and a bit more of a deep dive into the needs around older people and complex emotional needs. So if I could have the next slide, please. I'll just introduce the community mental health programme. As you will be well aware, the long-term plan and its predecessor, the 5-year forward view for mental health, had significant commitments around support for people with mental health problems in the community. The two highlighted here in the pink colour are the long-term plan, so the new element that came through as part of the community mental health framework within the long-term plan. And the three below are kind of commitments that have been a bit more long running and part of the 5-year forward view previously. But this in totality, I guess, is our work on community mental health from the national programme point of view. And I guess the key takeaway from this is that the community mental health programme was the biggest aspect in terms of funding of within the long-term plan. By the end of next year, there will be an extra £1 billion going into systems specifically for the transformation and increased access we want to see in community mental health services. And the two sort of key targets we've got as a programme are in the number of people that are going to be seen within the new transformed models of care, and I'll talk a bit about that in a second, as well as expanding access. So we're both making sure that more people can get support and also transforming and doing that differently and better, we hope, and reaching more people, as well as providing them with the better kind of support that we know that they need. So within that wider transformation, there are also 3 dedicated focus areas. We call them areas of specialism, I guess, where we know that we need to do more in terms of providing that kind of support for particular needs. There are eating disorders, people who are on a mental health rehabilitation pathway, and adults and older adults with a diagnosis of personality disorder. And I guess the first caveat in a presentation and a whole webinar of a number of caveats around the use of the term. So this is not just meeting people with a diagnosis of personality disorder, because that does not capture everyone we want to get who need support. And as a programme, we talk about the need to support people's needs and addressing people's needs and making sure there are services to support them, be they within the NHS or provided by other local partners. So if I can move to the next slide, please. Yeah, so here's a bit more detail around the community mental health framework, which is, if you're not familiar with it, is where the detail in the long-term plan lies. So this is a much more in-depth description of what do we mean when we say we're going to transform community mental health services. And I'll just pick up some of the key principles and themes here, which apply to the specifics around personality disorder as well, but are across the whole programme. Tailored services that are based around individuals' needs and their whole life needs. So we're wanting to connect the clinical support that might be required to the social support and to the support that might be provided through local authorities or other parts of the system. So moving to a system that wraps support around individuals and doesn't ignore the fact that there are other aspects of their life that are impacting their mental health, and tries to support them in that in a more holistic way. Services that are delivered as close to home as possible, and for the community transformation, this is a shift towards provision and access at a PCN level. So making sure that the support that people need is as close to where they live as possible, and that's how people can enter. I guess, yeah, it's called a one-team approach here. So this is really linking up the local NHS with non-NHS providers, both local authority, but as we'll see throughout today, I'm sure, voluntary community sector organisations play such an important part in terms of both provision, understanding of local need, and particularly reaching parts of the community that the NHS struggles to reach. And then another principle around co-production, already mentioned today from the Mentimeter, an absolute core of what we're trying to do in community mental health transformation is embedding co-production and co-design and making sure that people with lived experience are fully part of the design and delivery of services, and making sure that in decision making throughout the design services and delivery services that people with lived experience are involved. And I think particularly for this area where there are controversies and disagreements around what a diagnosis means, and also embedded long-term stigma, and it needs to be much more about needs-led. I think that need to have lived experience involved in development of services is all the more important. Next slide, please. So in terms of, and this may be familiar to people, but in terms of what we know doesn't work and what people currently experience or experienced certainly before any of the transformation has begun, typically long waiting lists to get to access the specialist psychological therapies, which are the kind of bedrock of some of the sort of clinical support that people need. Obviously that exacerbates existing problems and feelings of not being supported by services. Too often people are bounced between services, perceived to be not unwell enough, too unwell for some and not well enough for access others, leaving people kind of detached from services, disengaged and not getting any support. We know this is particularly true of marginalised groups, and the importance around cultural sensitivity and understanding where people come from and their backgrounds. I think in terms of stigma, this is a particular area in terms of diagnosis as well. We know that some people will are more likely to have one diagnosis than another because of their maybe their ethnicity or their background. It's a really important point. I think we'll come back to it numerous times today around diagnosis. It is a very controversial area because a lot of people do not have been diagnosed with, say, a personality disorder, and it doesn't connect with them, doesn't reflect their experience, doesn't reflect what their own understanding of what they need, which is why we have moved towards a focus around needs. What does an individual need? What's right for them? The element of co-production of care planning, element of involving people in the design of services is really about making sure that services are addressing what people want and need, rather than giving someone a label and providing a service that fits that. That is where we're absolutely moving away from. And I guess a caveat about the term complex emotional needs certainly has a better fit, but in terms of for many people, that is just a different label for the same thing. So really need to be sensitive around the issues around the stigmatization of people with a diagnosis in this field. Again, people can be very trapped between various care pathways, not getting the kind of support thereafter. It might be in many different multiple different pathways through different providers, and feel that kind of connection between services. They're having to do the legwork, having to explain their story multiple times. That isn't right, and that's something that the transformation is trying to achieve by connecting these sort of specialist services within that overall model. And then finally, understanding trauma, and I'm sure we'll get this theme throughout today. Making sure that services understand the role of trauma within people's stories, and understanding the impact of adverse childhood experiences, no matter how old an individual may be, making sure that services understand, support those, and the last thing that they should be doing is re-traumatization of those and re-stigmatizing some of those experiences. So there's a lot to do for sure, and there's a lot that needs to be done better. Next slide, please. So yeah, this is a very busy slide and there's lots of information on it, so I won't go through it all, and you'll get this afterwards. But this describes what we're trying to achieve in terms of our new model, and how is termed the dedicated function, that is for the areas I talked about, including personality disorder, complex emotional needs, and the core community mental health model, which is relocated to a primary care network kind of footprint. So what it involves is access to that truly personalized, trauma-informed care that is flexible and is considerate of their needs, and that's the needs of their starting point. It is also about linking to the core community mental health function, which encompasses both primary and secondary care, and integration with primary care is just fundamental to this program and this transformation. Involvement of the voluntary sector and things like social care, and making sure that individuals undoubtedly who are needing support through the sort of more specialist part of the service will also be able to seamlessly access that kind of support, which they will need as well. So there's no delineation as such from the person's point of view about the special service and the core function. As I've said before, the importance of co-production, I'm going to say that numerous times, and I'm sure people get bored of it, it is so fundamental. The involvement of lived experience at the heart of development and delivery of services. And I think that means paid roles, and it means paid roles at different levels of seniority. So there is a career pathway for individuals who are providing their expertise, on an equivalence with the clinical expertise. That is really, really important. And then finally, the kind of seamless stepping up and down of care. An individual may have periods when they need the more specialist or the greater emphasis on that sort of specialist support, but that can be stepped up and down without referrals, without there having to be any kind of fragmentation between different support being provided by different teams or different parts of the team. There's lots of different components there. I won't go through all of them again. Key themes here about co-production, involvement in lived experience, and integration with other parts of the system, including voluntary and community sector provision. And next slide, please. So again, interesting to reflect on the Menti poll at the beginning of this around people's awareness around training. Training is obviously totally, really important part of what we're providing to systems. At a national level, the kind of three priorities are in, improving access, so making sure there are more staff with the right skills to provide the evidence-based therapies, making sure that all staff, not outside of those that are just providing the sort of therapies themselves, are skilled and have a better understanding of the needs, presentations, the understanding around personality disorder and complex emotional needs, to remove some of that challenges around stigma, which is a really key part of that kind of culture change that we want to see. And I think there's a really important element there around connecting this sort of specialist service to the wider community services, because people can experience that stigma and views that don't reflect or that re-traumatize individuals. That could be at any part of connecting with the system. So it's important that we provide those skills and support people across the whole of services to understand people with these needs. And I would just highlight here on this bullet point towards the end the knowledge and understanding framework, the CUF training, which is a trainer model, which is really about helping achieve that culture change and broadening people's understanding of people with personality disorder or complex emotional needs, and what their needs are and how to best support them. Next slide, please. So yeah, so this is where we want to get to. This is the kind of how we want, what we want to see is the results of the transformation and what services to offer people, joined up services that are seamless, as I've mentioned, timely access to evidence-based psychological therapists. This is bigger than just this area, especially, but particularly important here. We want to make sure that there are people that can access those psychological therapists that they too often wait very, very long time for, if they ever get them. Supporting, making use of what's already in the community and understanding, the voluntary sector provision and community support that can play a part in supporting people and enabling people to live well in their communities, making sure that outcomes are a key part of this, and making sure that services are both recording outcomes, which is absolutely should happen, but also using the kind of insights you get from understanding that to improve services and continue providing personalised care. As I've mentioned before, paid, substantive, lived experience roles within the organisations, within services, within commissioning. It's really important to make sure that the service providing are those that meet the needs of people with complex emotional needs. Removing barriers that stop people accessing services, making sure that trauma-informed care is really fundamental to the provision of care. And I think that can go beyond just specialised services. It's important across community mental health. And making sure that services are working collaboratively together with individuals, and I guess a move away in terms of a kind of approach that kind of focuses on risk and tries to manage that thinks about safety planning as with the individual and supports them, rather than saying, oh, I'm not sure about somebody and the risk here, therefore reacting to that. Next slide, please. And then I just want to touch upon before I finish, I'm running out of time, but so although we're talking about older adults today, we're also there are a huge range of equalities that we want to see advanced and tackling inequalities. We've developed this roadmap for this covers the whole of the transformation to identify for systems. These are the component parts of what transformation looks like, and within that, the highlighted ones here you can see are specifically around tackling inequalities. And I think a lot of those things will apply for older adults as they will for younger adults, as they will for people from particular ethnic backgrounds. So what systems need to be doing is thinking about these with a particular lens. Today we're talking about older adults and making sure have they thought about these in terms of their transformation. And of course there will be intersectionalities. So there will be older people who are from a background, from a particular ethnic background. So we're continuing as a programme, and NHS England role is to support systems with their thinking and provide, good practice and advice on how to make sure that services are meeting the needs of all the people that they need to. And then final slide, I think I'm on. Oh no, there's two more. So we've done a bit of work nationally around reviewing all the different plans that systems have provided for the year ahead in terms of tackling inequalities. So this is just a sense of where systems are. There's more representation around marginalised communities in governance structures, which is great, because if you don't have that representation, how are you genuinely hearing those voices? Systems are taking this seriously and are taking actions to try and tackle inequalities, and lived experience is being brought into design, and I think there's probably more to do around decision-making structures, but it's good to see that there is progress across systems. And then my final slide is just to show you, we ask what particular areas of focus do you have, and as you can see, older adults is just beneath younger adults as the most popular area where systems are saying we are doing specific work around older adults this year with a lens of tackling inequalities, which is great to see. Obviously, for all of these, we'd want to see 100%, but only some attention. You have to focus somewhere. So, and today it's older adults. So that's all from the national perspective. I think I'm going to pass over to Tasha from Hereford and Worcestershire. I'm very hopeful, at least.
I think Tash should be being connected now. Tash, otherwise, yeah, we can hear you now, Tash.
Excellent. So let me start with a sorry, everybody. We've had some technical difficulties, so I am joining by phone. I will do the best that I can. So obviously I can't see or engage with anyone. So let me start. So I'm Tash Lord. I'm a clinical psychologist with Herefordshire and Worcestershire Health and Care Trust. I'm also the Vice Chair for the Faculty of Psychology of Older People, or FPOP, as we're commonly known. Amanda, can I just do a sense check? How loud am I? Is that okay?
Sorry, yeah, that's fine, Tash. Yeah, you keep going, and you just say move the slides on and they'll move. Okay.
Yeah, lovely, thank you. Let me know, because obviously I'm talking to a phone. So next slide, please.
It's up.
Okay, it's not showing on my screen, so I'm just going to have to try and keep going, and we'll see what we can do. So over the next sort of 25 minutes, I want to give a brief background into older people and complex emotional needs. The research is actually going to be covered by Catherine later in the presentation. But what I want to do is provide a bit of context in terms of why we scoped the need. I noticed that there were questions coming through about older people and prevalence, what that looked like, what were some of the themes and the outcomes, and where next. Next slide, please. So in terms of where I'd like to start, if that's okay, is actually I've worked within older adult services since I qualified in 2010. I've worked in the NHS since 2003. And I guess what I was reflecting on is I still hear today nationally from people in terms of, well, it's not really relevant for older people, is it? You know, older people, they're not as risky, or you won't now see me doing inverted commas, but you know that, you know, it just burns out. You still hear that in terms of this suggestion that self-harm, expression of distress, that it doesn't happen for older people. And Sam, what I'd like to do now is play a short 2.5-minute video by Professor Kapoor and Dr. Morgan that just highlights why today's webinar is so important. And I'm so pleased to hear that we've got over 500 people that have joined. So Sam, if you could just show that for me, please.
So this study was about self-harm in older adults. And when we talk about self-harm, what we're really referring to is self-poisoning, often with medication, self-cutting, or other forms of self-injury. In this study, the majority of episodes, about 80%, were self-poisoning. So we often think of self-harm as an issue, as a problem in younger people. And this study is a reminder that it's an issue in older adults too. And the really important thing is a particular risk factor for suicide in this age group. So self-harm is a risk factor for suicide across the age range. But in this study, we found that older adults who self-harmed were about 145 times at greater risk of suicide than older people who hadn't self-harmed. Suicide prevention is a big priority at the moment, a big health service priority, a big public health priority. We've just had a minister for suicide prevention appointed in the UK. And the study really shows how clinicians, service providers, policymakers should see self-harm as an opportunity to intervene. What should we do? We should make sure that older adults who have hurt themselves are properly assessed. We should make sure that psychiatric illness and psychological factors are taken care of and managed and treated. We should be thinking about risk factors for suicide in older adults, so treating physical illness, thinking about bereavement as a risk factor, and social isolation. And the other thing I think this study highlights in view of the medications prescribed after people with self-harm is the need for careful prescribing and medication.
We use clinical practice research data looking at self-harm in older adults from a primary care perspective. We found that there was a high mortality risk, and certainly after during the first year following self-harm, those people that harm themselves were 20 times more at risk of natural death, and there was high risk of suicide also over a period of 14 years. When we looked at clinical management during the 12 months following self-harm, we found that there were low rates of referral to mental health services and high rates of prescription. With those patients being prescribed with tricycline, about 1 in 12, which can be toxic in overdose.
Thank you very much, Sam. I'm not going to labour the point. I think for me, it is a really good summary of why today's webinar is so important, that we're starting to consider the needs of older people and older people with complex emotional needs. So next slide, please. So in terms of our journey within Worcestershire, it actually starts in spring 2019. Sorry, I'm hesitating just to make sure that we've gone back to the slides yet.
Well, on the right slide, you are.
Oh, lovely. Thanks, Amanda. So we have, so our adult mental health colleagues were successful in a bid to develop a specialist tier service for people with complex emotional needs, led by Karen Ingram. I'm going to do a shout out for her, because actually it's those relationships that we have with people that make the difference, and what they were looking at the time. And Jeff, I didn't get to hear your presentation, and I'm really sad about that, because you spoke about co-production, and that's where Karen had started. So she'd opened it up to the public, and that included ourselves in older adults, but also learning disabilities and CAMS. And the conversations were about the service being age inclusive. And as we carried on, we realised that perhaps we didn't know what the demand and the need was within our older adults. And we were specifically asked to go away and look at that and develop our own business case alongside the one that was already running. At the same time, people will be aware that in January of 2019, the long-term plan came out, and obviously Jeff has just been talking in terms of the community transformation. So there were a number of agendas that we were thinking about. Now, next slide, please. The reason I was saying in terms of having that context is when we started and why we needed to do the scoping exercises, research, and Catherine will go into this in far more detail than I'm going to now, but it's actually poor for people with complex emotional needs, but especially poor for older people. So people asked in terms of prevalence rates, and that will be captured later. We know that it's potentially equivalent to people of younger age, that complex emotional needs present differently for older people, that older people are not likely to receive a diagnosis, and that can be for many reasons. One of them can be about, for some people, it may be that those needs have been there, but actually they've been within employment, perhaps there's a husband or wife, there's been those structures that in place that have supported that person. And then as Professor Kapoor was saying, in terms of those risk factors, that scaffolding has fallen away in later life or in terms of aging, and then those needs have emerged. But from a diagnostic criteria point of view, you don't have that pervasiveness over the course of the lifespan. Or sometimes it can be disenfranchised, where it's thought about that because it's a person is older, than what happened in childhood isn't considered. Next slide, please. The other thing that is important to consider is that assessments that are currently out there in terms of looking, you'll hear me use the word complex emotional needs. That is the language that we've adopted within our trust. It is what's adopted, I think I heard Jeff say earlier, as we know, within NHS England. Where I use the term personality disorder, that's in reference to prior publication, or it's in reference to diagnosis. But so the assessments that have historically been out there in terms of looking at, for an assessment of personality disorder, do not have face validity for older people. So this is important when we're thinking about why did we do this scope. There was no measure in terms of thinking of, okay, what is our demand? Next slide, please. So as I mentioned earlier, I'm a member of the SPOT, so the Faculty of Psychology of Older People National Committee, and there is a psychological work stream which Catherine and I and Polly Kaiser are part of. And we realised that in order, anecdotally, if unfortunately I don't know who's on the call, I'm hoping there's commissioners, I'm hoping there's people from adult mental health services, older adult mental health services. If you speak to older adult clinicians, they'll say, I've been thinking about this, I've been wondering about it, but we didn't necessarily have the measures in place to be able to articulate that to then say about what those services look like. So what happened is we came together to say we needed to look in terms of parameters. I'll go on to describe those in a minute. What's been really interesting, and I think this webinar for me shows it in terms of the number of people that signed up, is it originally started in Worcestershire, and that came obviously on the back of what was already happening. Greater Manchester in terms of Salford and Bolton took it up shortly after. We've got Gemma Graham, who is leading in Rotherham, Shona Scott in Sheffield. We've spoken to other trusts that have done their own internal scopes saying, we know something's going on, we've been looking at it. Pennine Care. I was speaking to Birmingham and Solihull last week, and they were having a conversation saying that they'd been looking into their diagnostic rates across the lifespan and felt that it wasn't reflective and that they needed to think about it. And just yesterday, I had 2 conversations with different trusts asking me for the scoping exercise so they could think about their own needs. So we're getting a real groundswell, I think, of recognising that this is a need that we need to consider differently. Next slide, please. I've still got that delay, so I'm going to assume that it's gone through. So in terms of the parameters, the first one looked in terms of being able to identify who may have a potential complex emotional need. So we looked in terms of relational difficulties. We know that if we're not meeting a need, that a person will have poorer outcomes in terms of having that need met and potentially will come into services more often. So we looked in terms of the number of times somebody had been referred into the service. We looked in terms of what services were being used, how frequently, what the intensity was like. So that was the first set of parameters. Next slide, please. The second was then to start to drill down into that information and to look more closely. So as I mentioned earlier, diagnosis doesn't necessarily reflect need. So we looked in terms of what were people's current diagnosis, was their experience of trauma, thinking about early trauma, also in terms of, as Professor Kapoor was saying, risk factors. So had somebody, had there been a death, or was somebody socially isolated? Was there retirement? Was there changes in terms of people's physical health and related to aging? We were also interested in terms of the literature that was saying that expression of distress is different in later life compared to people of working age. It started to be some of the areas that we wanted to delve into more thoroughly. Next slide, please. So in the methodology, the reason I put this slide in, as I mentioned earlier, we've actually pulled it together into a bit of a pack. So we've got the methodology in terms of what we did. We have the parameters that have been put into a questionnaire that can be used. We set up a database and we share that with people alongside the presentations of some of the information that we've found. So within this, we developed a criteria. I think it's really important that I was talking to someone recently who said, you know, 10 years ago, if we were having this conversation, we wouldn't have got anywhere. But when we're starting to talk about it now, people are saying, actually, no, I think, you know, we've noticed this and we're not meeting this need. And actually, it's really detrimental for the person, for the families, for staff who are wondering, but also in terms of cost. And I'll go on to talk about this. So we warmed the context. We distributed that questionnaire. I've got to do credit to Hannah Biney. She was a trainee clinical psychologist with me at the time. So it is a resource intensive, looking at, okay, let's delve deeper into the information we had, created that database, and then we've reviewed that information in line with the current database. Next slide, please. So in terms of some of the themes, and I'm sorry that I'm whistle stop all the way through and that you're not able to see me, but there's actually quite a lot to cover, and I think today is that continuation of that conversation that will carry on outside this webinar, that will continue to connect, that will continue to share, and will continue to build the evidence. So in terms of themes, we've got about diagnosis, high use of services, the literature about how things for some people may emerge in later life. We've got in terms of physical health. Now I know that physical health for people with severe and enduring mental health difficulties is poorer, and in terms of people's life expectancy, it's less. But when we think about old people, and again, referring to that video and the work that happened particularly in Sheffield, is looking at potentially multi-morbidity, that in terms of frailty, and as was mentioned earlier, in terms of polypharmacy. We've then got in terms of recognising that relational difficulties do happen in later life. What's the expression of distress different? And what does our intervention look like? Next slide, please. So today, I've been really fortunate in terms of not only being able to share the data from Worcestershire, but the other trusts that I mentioned have also given consent for me to share their data. I'm not sharing everything, that's just not possible, but what I wanted to do is highlight some of the themes, because sometimes it can be, well, is that the Worcestershire, but it would be different for ourselves. But actually looking at what the literature says and what's coming out of the trust. So for ourselves, we had 535 open referrals at the time when we did our scope. And using those first set of parameters, we had 72 people that we identified that may have complex emotional needs. As you can see on the right-hand side, half of people had accessed our inpatient services, almost 40% had accessed our inpatient services, and also used home, sorry for the acronym, home treatment team and crisis team. You've also, just coming down again, and this is in terms of, but for me, I'm thinking a number of things when I this slide. As I mentioned earlier, we're thinking about the person, okay, what the experience is, what the potential consequences and harm can be, not only for the person, the family, and also for the staff, but there's also cost implications. So as I said, I don't know who's on the call, but part of what we need to think about is if we're not meeting the need, it's also not cost effective. So what you can see here is that what we identified was that approximately 8%, so half of people had been using all of our older adult mental health services, and half the people had been using all services, including primary care and emergency services. Another fact that I just wanted to, information that I wanted to bring your attention to is the bit that I mentioned earlier. So in our scope, we found that 31 or 43% of older people had not had prior access to adult mental health services. Now, this is important in terms of when we're thinking about access to services. When you're thinking about setting things up, I mentioned earlier in terms of diagnosis. So potentially there's an unmet need goes on being unmet. Next slide, please. So another one, and again, this is just to show some of the themes, Bolton and Salford, so that was with Catherine, who's speaking later. When they looked at those first parameters, what they found is actually that all the people on their caseload potentially would be recognised as having a complex emotional need, and they drilled their data down further. So they looked in terms of whether a person had difficulties in maintaining relationships. You can see that it says considered because obviously it's the clinician's view. And I just again want to highlight in terms of some of the information you can see. So 2/3 of people had been in service for over 4 years with a mean of 9 years. You can see 3/4 of people had access to inpatient services. And going back to that, if we're not meeting the need, then there are poorer outcomes and it's likely to result in further referrals back into service. You can see that it was almost 100% of people that were then experiencing that. Next slide, please. So I mentioned in terms of diagnosis, and I know there were questions earlier in terms of diagnosis, and I'm sorry that I can't talk to those within the time that we've got. I think the reason that this is important, and we had, I'm really grateful to our adult mental health colleagues because we've had lots of conversations in terms of how our age inclusive services are set up, in terms of thinking about access, appropriability, sort of wider system. And Jeff, I only caught the end of yours in terms of trauma-informed care. But we know, so within Worcestershire, and I can only talk for Worcestershire, in order to be able to access our complex needs service at the moment, a person needs to have a diagnosis of borderline personality disorder, a cluster of Honos 8, and then it's looking at risk. So what you can see here, and I know this slide is really busy, and forgive me for that, but I do think it's important sometimes to see those different bits. Within the top, so this was Sheffield, you can see that the highest diagnosis, so we know that there's, and Catherine will talk about this, that there's a comorbidity with depression, so that is the highest number. You can then see that it moves on to anxiety, with the lowest one being a diagnosis of personality disorder. And then down at the bottom again, that is Worcestershire, with again depression coming out. Rotherham said the same. So we're seeing those similar themes in terms of that diagnosis does not meet that need. Next slide, please.
Tash, you've got about another 5-6 minutes left.
That's okay. I can see it coming up, and I've got a stopwatch, so I'm keeping myself to time. The difficulty is there's a lag between.
Yeah, well, it's on service provision now.
Lovely, thank you. So this is only brief. Again, it's coming back to in terms of thinking about when we're setting up services. For us in Worcestershire, obviously this led to a business case. If anybody wants to talk to me afterwards in terms of what we were thinking about that, we can share that information. But I wanted to show these two slides in terms of just recognising the number of professionals involved And then again, I heard Jeff just at the end, it was a bit tinny because I was on my phone, saying in terms of having access to evidence-based interventions. What we've noticed historically and what's coming out anecdotally is what you can see is a CPM visit followed by psychiatric review. And where there is psychological therapy, it's individual therapy, it's not a team-based whole system approach. Next slide, please. So just in terms of presentation, again, coming back to the literature, I think it's really important to think, okay, what is the same, what is different for people of later life compared to people of working age? And what you can see here is that we, between Bolton and Salford, Worcestershire, and the literature is we're finding those similar sort of things. So you can see within Bolton and Salford, they say about over half were recorded as neglecting themselves, that a third of people had engaged in self-harm. For us, and I wanted just to highlight this, we only in Worcestershire looked at primary expression of need. So we had 23% of people where the primary need was self-neglect. And then when we looked in terms of people who had self-harmed, what we found is that the highest number, the 23% of people, had taken an overdose of medication. So again, going back to those things in terms of thinking about what is different for older people, how do you identify that risk? What does it look like? What should you be looking out for? What could that potentially mean, going back to Professor Kapoor's point? Next slide, please. Amanda, I'm still stuck on diagnosis. Can I just make sure you're on service and interventions?
We're on services and interventions. You're doing fine.
No, thank you. Okay. So in terms of this, and Catherine will talk more about it, as I was just saying, people historically within older adult services, it has been, so anecdotally, and Rotherham was saying this, it is looking in terms of clinical care coordination, psychiatric review, and potentially individual therapy. Now, one of the things that's kind of coming out of it, and I think is really important, and I heard in terms of that mention for training, is if you don't know the need that you're looking at, we're potentially not training staff in the right way. So there's a mismatch there. Also, and Catherine will talk more about this, is when we spoke with adult mental health colleagues and we thought in terms of our age inclusive offer, there are things about older people that they admitted they didn't feel skilled or competent with, and lacked confidence, and that also reflects the literature. So that can be things in terms of whether that be peer support, so in terms of the age of the group, and that ability to have that shared experience. They spoke in terms of the pace and how that could be different, the potential for repetition there was needed when they were talking to older people to help for potential cognitive changes, that it was needed in terms of thinking about barriers in technology. Now, I'm aware I'm running out of time, so I'm going to have to go quicker. The other bit, so I've already mentioned in terms of diagnosis, is that it doesn't necessarily reflect the need for older people, but in terms of assessment, as an older adult clinician, of course, you're also thinking about, are these difficulties potentially organic? Are we thinking about a frontal lobe dementia? So you're having to hold all those different sort of hypothesis of view and sharing and working with the person on that. Next slide, please. Okay, so thanks, Amanda. I'll get quicker. So I'm going to skip this one because basically there were some things that I wanted to really kind of come back to. So to say our outline was in line with the, our scope was in line with the literature. We really need to think about the potential cost implications. We need to consider about risk. We need to be able to develop things in a meaningful way that older people are able to access. We need to think about all those different areas. Next slide, please. So just briefly in terms of limitations, I'm aware that some people will be thinking about the scope. We know that this was not a validated measure. Jeff, you spoke in terms of co-production. We're aware that for this piece of work, no, we didn't have the service user voice. We haven't accessed the wider sort of business intelligence. the potentially artificial. However, what I would say, and I've been saying it all the way through, is that the conversation is changing. We are recognising that there are these needs, that there are different. Next slide, please. I'm going to go to take-home messages. So take-home messages. Yes, older people can and do have complex emotional needs. These needs are different from younger people, and we need to ensure that older people are able to access appropriate specialist provision, offer, however that's going to be set up. Next slide, please. So finally, I know I'm over time. I'm going to hand over to Catherine in terms of the recommendations. I think it is important that we understand what our demand and need is. We are able to support you if you'd like to follow our scope or think about doing your own. Jeff, you mentioned in terms of training, those myths still persist about older people aren't able to access therapy or don't benefit from therapy. It is not true. We are doing a lot of work alongside this in terms of structured clinical management adapted for older people, as well as mentalisation-based therapy and dialectical behavioural therapy. Get in touch. There are resources and webinars out there so we can support that. And basically, if you haven't started already, start now. Thank you very much.
Thanks very much, Tash. Brilliant being done on the phone as well. So over to Catherine. We'll light up in a second.
Great. Can we have the next slide, please? So while we're waiting for that, I'll just introduce myself. My name's Dr. Catherine Dykes. I'm a consultant clinical psychologist who works in Greater Manchester Mental Health Trust. I'm going to be talking today about the recommendations document, which has been written with colleagues, both psychological and psychiatric colleagues, and we're going to be talking a little bit about the research, just linking in with what Natasha's just been saying. Okay, next slide, please. I suppose it's important for me to say that really with the time that we've got this afternoon, we really are just covering the surface of some of this research. If you would like to read it in more detail, then please download the recommendations document, which is available free of charge on the Future NHS platform. I think we're going to try and put a link in the chat so that people have got that direct link to be able to access the full document if they want to read it in a bit more detail. So I'm going to talk about what we know so far, and we're going to be really looking at research evidence, which Tash has touched on, but I'm going to hopefully touch on a little bit more detail. Okay, so I think one of the themes from what Tash has already said is that things are different with older people, and we know that the clinical presentation is different. I've seen some comments in the chat about diagnosis and personality disorder versus complex emotional needs. We could have an entire webinar to debate that. I think what we do know is that psychiatric diagnostic manuals, the current research evidence, what is available in this area, and therefore the NICE guidance that feeds into, and the support and interventions recommended within that NICE guidance tend to be based on a working age presentation of complex emotional needs, or personality disorder as it's often referred to in those documents. But there's a growing evidence that actually the clinical presentation of older people with emotional regulation difficulties, impulse control difficulties and long-standing interpersonal challenges is markedly different from that of younger adults. So for example, we tend to see much more over-regulation of emotion in older people rather than the under-regulation that we might see in a working age population. And that makes things tricky. It makes it tricky in terms of using diagnosis. When I locally looked into how many people in the organisation I work for had, over the age of 65, had a diagnosis of personality disorder, it was a handful. And when I took that information back to the local teams, that was not reflective of the clinical need that they were supporting at that time. So without identified need, it makes it very difficult for services and commissioners to make available appropriate interventions and support for people. As we go through this afternoon, I'm going to be asking various questions. I'm not necessarily asking you to respond in the chat with them. They're just really to kind of encourage you to think about your local services and what's available. So I guess in relation to clinical presentation, my question to you would be, do your clinicians in your services consider the differences in presentations in older people in their assessments, and is that accounted for in the interventions that might be available for older people with complex emotional needs? Okay, next slide, please. So moving on, thinking about prevalence. We know that older people are less likely to attract a diagnosis of personality disorder. We know that the presentation is complicated by comorbid mental health difficulties, cognitive impairment and physical health difficulties, which are more likely in our older service users. And prevalence rates do vary considerably between studies. I know Tash has quoted a kind of 10 to 20% in a community sample, which is in line with younger people. But as she said, for some people, needs become apparent or seem to develop in later life, and that's about the scaffolding that comes with working age. It's hypothesized, so things like routine, work, family relationships changing as people age. So things like bereavement, loss, chronic physical health difficulties can settle the picture sufficiently for those difficulties to come to the attention of services and of other people. So my question to you is, are we gathering data about older people in our communities and services with complex emotional needs? Next slide, please. I know some people in the chat have been talking about trauma after the presentation right at the beginning from Jeff. We know that one of the main precursors of a diagnosis of emotionally unstable personality disorder is childhood trauma, but there's an interesting and kind of innovative amount of research now coming out. There's some papers there if people are interested in having a look at how older people, the language that older people use to talk about distress, to talk about their difficulties, what they understand if we ask them the question and we use the word trauma, what they understand by that. So there is a growing evidence that the language of trauma and adversity for older people is different to that of younger people. And we need to also be thinking about the how we view trauma in older people. There is a sense that trauma that happened when older people were children happened so long ago, maybe 70 years ago or more, that it almost no longer has a relevance, or that actually things which could be considered traumatic by the individual are just a normal part of aging, and so slightly dismissed by those around them. So things like multiple bereavements, various different types of loss and chronic illness. So my question to you is, are we asking people using our services the right questions, using the right language in the right way? And are we supporting our workforce and training our workforce to know the difference and to consider that difference in their assessment work for older people? Next slide, please. Okay, so thinking about outcomes. Again, interesting amount of evidence starting to accumulate. We know with older people there's a higher chance of relapse, reduced functioning, poorer outcome, and that this group are more likely to have complex and chronic difficulties. We know that older people that receive a diagnosis of personality disorder are more likely to display somatic, depressive and anxious symptoms and have higher functional impairment when compared to younger groups with the same diagnosis. And we also know that increased somatisation in care seeking leads to difficulties in the provision of care and longer admissions. And I suppose for those clinicians on the call, when I look back over my sort of clinical career, I can certainly think of people that I've worked with who have, if you like, bounced around the system. So they have had multiple admissions into inpatient care, or very, very lengthy admissions, or they have been discharged into maybe supported accommodation or residential care, and that placement has been maintained for a period of time, and then the person has been moved into a different care setting, and that again a limited amount of time in that care setting and then moved again. And so we get people that are kind of almost bouncing around the local care system, and it's very, very difficult to maintain a kind of long-term placement and long-term support for them. But I'm not sure that we always consider and offer treatment about relational and emotional difficulties to that cohort of people. So my question is really, are we considering that within our local clinical services? Are we considering those relational and emotional difficulties for people who might have lots of inpatient admissions, lots of transfers of care, or particularly lengthy admissions in our inpatient wards? Next slide, please. Tash has already spoken at some length about risk, so I'm not going to labour the point. There are some really interesting and useful studies which are emerging around the difference with older people in terms of risk, particularly the risk of self-harm in older people and how that is much more likely to translate into completed suicide than it would be for younger people. That's the work that's coming out of Manchester University, but also there from Matar and Khan. Older people that do receive a diagnosis of personality disorder make up 44% of completed suicides of older people. So we need to be thinking about how risk presents differently and how we're supporting and identifying this group of people. So I suppose that there will be people on the call who work in age sort of equal services, age inclusive services, and also people who work in specific older adult services. And I think the issue here is about how we're supporting our staff, regardless of what kind of service they work in, to identify these presentations of risk in older people. And that might also include maybe staff working in A&E, our mental health liaison teams, as well as our community services. Next slide, please. Okay, when I looked in Microsoft and I looked for an image to represent older age, this is the only one that is available. So I would just like to make the point that I'm sure we're aware there are many, many older people in our services who are absolutely vibrant and not necessarily experiencing physical health challenges and full of energy and vigour. But we also know that for many older people, there are more chances of frailty, more difficulties with physical health. And I guess what that means for that group as they age is that the systems of support and care around them become increasingly complicated. More people end up getting involved. There's more support in relation to physical health that's required, maybe more use of primary care and urgent services. And really what we're talking about with this group of people with complex emotional needs is difficulties with relationships. So the more support that people need, the more likely it is that those difficulties with relationships become problematic, if you like, for the individual and lead to heightened distress. So as people maybe have carers coming into the home, as they move into supported living or different care environments, it can really accentuate what might be long-standing interpersonal complexities. And that can lead to stigmatization of that individual. And as I say, excuse me, increased levels of distress. There's also been some discussion, I think, in the chat around cognitive impairment and dementia. And as Tash has also mentioned, we know that those things are more common in older adults. So we have the additional complexity in older adult services of people with complex emotional needs, so long-standing emotional regulation and interpersonal difficulties, who are then going on to develop impairment in cognitive functioning, which further complicates provision of care, especially if people need hands-on physical care, linking back to the conversation that we were having before about the high incidence of childhood trauma in this cohort of people, and just the impact of that on how we best support them, really. We also know with older people that polypharmacy is more common. So there's a need to review and deprescribe to make sure that we're reducing the likelihood of that, and also considering the impact of physiological health on mental health. And given the points I've already made about risk, we also need to make sure that we're reducing access to unnecessary medications from a risk perspective. Now, again, I think this point has been made in the chat about resource, but the RCP in 2018 made a very clear statement that adults over the age of 65 do not have the same access to specialist mental health services as younger people. And also that older age services have been excluded from investment and have seen reduced resources. Again, I think there's some discussion in the questions on the call about whether that is continuing with community mental health transformation funding. So my question to you is, are our local services set up excuse me, to allow different needs associated with ageing to be supported clinically? Next slide, please. Moving on then to think about interventions. We know that many of the NICE recommended interventions, nearly all of them for personality disorder, are psychological in nature, with medication being used to treat coexisting conditions. Tash has already referred to, there's a couple of references there, the kind of ageist beliefs really that older people can't benefit from psychological therapies, which are not true. We know certainly in primary care psychological therapy services that our old, so people aged 85 and above, are 5 times less likely to be referred for talking therapies. But the evidence shows that those talking therapies are just as effective for older people as they might be for younger working age people. There's currently no evidence to suggest that the NICE recommended psychological interventions, which are recommended for people with complex emotional needs, are not suitable for older adults. I think what we need to be thinking about is the pathways to access, and diagnosis is a key barrier for many people in terms of access to pathways. We need to be thinking about the adaptations that are required to those interventions to make them suitable for older people, given the difference that we've already stated in terms of clinical presentation. And then given the lack of an evidence base, we need to be developing practice-based evidence. We need to be measuring outcomes. Okay. So again, my question to you is, would an expected proportion of your older adult community access psychological interventions for complex emotional needs currently, based on the prevalence that we've already discussed? Next slide, please. Okay, so off the back of the National Expert Advisory Group for Older Adult Mental Health and Dementia Care, a group of us came together to write recommendations for services. And these really are core recommendations. What we wanted to do is give some information for services about what they should be developing, evaluating and delivering for this group of people. We've grouped them into the areas of data, workforce skills, service development and assessment for clarity. I think much of the focus often is on intervention. My view would be that we can't be offering meaningful interventions unless we're also considering the other 4 areas equally. And hopefully, both for service providers and commissioners throughout this document, there runs the need to remove the inequalities and barriers for older people that currently exist. Okay, I'm going to move us on because I'm aware that I'm running out of time. Thank you. Okay, so as I've said before, if you want to look at this document in more detail than we have time for today, please do so. It is freely available on the Future NHS platform. But I'm just going to very briefly take each of these areas in turn. So in terms of data and research, we need to be ensuring that older people have equitable access to quality interventions and the opportunity to participate in research. And I think we've made the point a number of times that actually we're not quite sure what the clinical need is because we haven't historically gathered data. I've had various conversations with people over the years where they've told me about data, and then when I've queried whether older adult services are included in that statistic, the answer is no. So we need to be really clear about the information that we're gathering and make sure that we're gathering data around older people in respect to the local population, but also in respect to the interventions that they're accessing. I've already mentioned we need to be making sure that we're using regular outcome measurements so that any adapted interventions available for people, we're assessing whether or not they're effective. And we also need to be asking people in an age-appropriate way for feedback around the care and support that they're receiving. Next slide, please. Moving on to workforce skills. So this is about ensuring that the workforce has the opportunity to build confidence and skills in this area, making sure that people have access to training in relation to trauma and trauma-informed care, which runs like letters through a stick of rock in relation to community transformation. And also that staff have access to training on clinical skills and clinical interventions. I know there's been some discussion in the chat about those. We haven't got time today to go into those, but Structured Clinical Management DBT and MBT, which are the HEE Commission training offers, but I know that FPOP are kind of running various webinars on that, which I'll refer to in just a second. And then we also need to make sure in terms of ongoing support for staff that they have access to specialist supervision and consultation from older adult specialists, and that gives people an opportunity to consider the emotions that are evoked by this work, which is looking after our staff is a key aspect of trauma-informed care, and in the NHS at the moment should be a key element of what we're doing. Next slide, please. Thinking about service development, there's already been some mention, I think, by Jeff about peer mentoring. Paid peer mentor roles, a fantastic opportunity. I have personally yet to really see them take off in older adult services and these opportunities be offered to older people equitably, bearing in mind that there may need to be some reasonable adjustments required. In terms of community transformation in our community services, when we're working with VCSE partners, we need to make sure that older adult specific VCSE partners have an equal seat around the table, and that older adults themselves are equally involved and invited to be involved in co-production of services and interventions. And again, reasonable adjustments may be required. The allocation of resource, I think the RCP document does make the point that older age services have been historically underfunded. So there is an argument that actually older adult services require a greater than equitable proportion of funding to bring them up to a level playing field. I think I would also make the point here that when we're talking about distribution of resource, I think it's not just about financial resource, it's also energy and motivation and enthusiasm and strategic thinking and direction needs to be equitably happening and shared across our older adult services. And then finally, we need to be thinking about some of the practical barriers and removing them so that older people can access services. Next slide, please.
5 minutes, I'm afraid. Catherine.
Lovely, no worries, no worries. Okay, moving on to think about assessment. So I've already mentioned language, making sure that staff are thinking about the language that they're using to be able to offer meaningful and supportive assessment, which gets to the kind of nub of a person's difficulties, both in terms of their life experiences, their trauma experiences, any risk issues and their emotional state. We need to be considering complex emotional needs when we're formulating need. And we need to be absolutely thinking about the differing presentation of risk in older people in terms of our clinical assessment, which leads on for the need to older people to have a robust crisis plan, which has been developed jointly with them. To make sure that older people are active participants in their care. There's some things there which I think we would hope and expect to be included in a robust assessment. That's not an exhaustive list by any means, but in relation to complex emotional needs, I would expect those things to be included in assessment. And one thing that I think older adult services are really very good at actually is providing systemic care. So really thinking in assessment about the system that sits around the person and how they can contribute to the assessment and also support interventions for the individual. Next slide, please. Okay, so finally moving on to think about interventions, and we could spend a webinar talking about each of these 5 different areas. We haven't got time to do that today, but this is about ensuring that interventions offered to older people with complex emotional needs are suitably adapted to meet the needs of that population. And this is where it's important for access to interventions and pathways to be based on clinical need, not diagnosis. I think if access to pathways and interventions is based on diagnosis, then for all the reasons that we've already said, we know that a proportion of people with complex emotional needs will just not be able to access the care that they require. We need to make sure that older people have access to a range of high quality, NICE recommended interventions delivered by trained and accredited practitioners, and that those interventions have been adapted to meet the needs of older people. That's the ask from the Community Mental Health Transformation Agenda in our working age services, so that doesn't need to be any different in terms of accredited and trained practitioners in our older adult services. We know that NICE guidance says there should be an appropriate MDT around the person. And that people should be involved in their care, which should be as honest and collaborative as possible. Older adult services should neither be overly paternalistic nor risk neglect by offering a level of care which is below that offered to other people within our mental health services. And then finally, the importance of important others, family, carers around the person with complex emotional needs, and making sure that they're getting appropriate support, whether that be psychoeducation, carer support or signposting. Next slide, please. Okay, so this document is really not been out for very long, but we've already had some feedback from Nottinghamshire about how useful they found it in informing discussions around equality of access in transformation, but particularly in relation to people with complex emotional needs. They plan to use the recommendations to audit their services and guide development, and also to think about how they inform thinking about staff knowledge, skills and training. Okay, next slide, please. So these questions, I'm not expecting people to answer them now. They're really just, again, to get people reflecting on their local services and where things are up to. Tash has already mentioned FPOP, and we do run a series of webinars. If you are, next slide please, Sam, sorry. If you are interested, we also have a community of practice, which is a free email address. So if you would like to join, then please email natashalord.nhs@nhs.net. We will sign you up, you will hear about the webinars, and we can continue the conversation, I think, in terms of developing access for older people. Okay, back over to you, Amanda.
Oh, thanks so much. That's really brilliant. Great going through everything. I know there's a lot for people to, and there've been a lot of questions. I just want to ask Jeff a question. Please, Jeff, you there? Yes. So we've had lots of concerns about perhaps a national team not making sure that the system is looking out for older adults and older adults missing out. Can you kind of tell us what the national team is doing in relation to that, so we can be reassured?
Yeah, well, I mean, I think the question pointed out the 88% of systems that are planning to focus on this year, and I think the comment was, well, we haven't seen that yet. I would just catch that in terms of the transformation. Firstly, it's incredibly complex what we're asking to do systems to do across the piece. It is a very complicated and involves lots of different moving parts, and most systems only started last year. So we're, rather than the whole long-term plan being about it, we had 2 years of an early implementer phase where 12 systems were working in this area. So most areas are only just beginning. So if you haven't seen the fundamental change yet, that's probably why, and it is reassuring that so many, the vast majority, have got it written down in their plans when we've reviewed them nationally. The national role is to have things like, days like today, and making sure the messages and support and best practice are filtering down to systems and services so they can utilize them in designing their services. But as the last presentation was just saying, there's nothing in the community mental health framework that says do this for adults but not for older adults. And the message we need to keep getting across on all manner of different qualities, but particularly on older adults, because I do agree we need to be increasingly visible about it, is that it's about adapting what you're doing to make sure that it's appropriate for older adults. It isn't necessarily about doing anything totally different. In fact, is that helpful? I think it's making sure that you understand what those needs are. Our role nationally will be to help that understanding. Equally understanding what the solutions are, what the good practice says. That point about assumptions that older people won't respond to therapy, absolutely, we need to be making sure that disappears as an idea. Ultimately, it is the way the NHS works. It is down to local systems to have their own plans to deliver their services. That's right. But yeah, our role is to continue to make sure that this is on the agenda, and that's what we're doing with this session, and we'll continue to work with you, Amanda.
Thank you very much, Jeff. And I can reiterate that Jeff really is working with us and thinking about older adults. So a question for you, Catherine. This was in relation to care homes, and how do we support care home staff to make sense and respond effectively to somebody with an older person with a complex emotional need?
Absolutely, that's a really good question. I think that at the heart of working with people with complex emotional needs really is the idea of relational recovery. So care homes often have staff, quite a transient workforce, not necessarily that much access to training. And I think in teams in which I've worked, what's actually been really valuable is going in, spending time with the staff, understanding their difficulties maybe, about working with and supporting somebody where they may be struggling, and that person with complex emotional needs may or may not have a diagnosis of dementia, and really encouraging them to think about how they provide care, how they form a trusting relationship with somebody, what that looks like, what the challenges to that are. We're not necessarily asking them to deliver specialised interventions. What we're asking them to deliver is thoughtful, containing care that provides good attachment for those individuals.
Right, thank you very much. Jeff, we've got one other question about data. Can I just ask you that? The question is it true that the community mental health transformation data will now be broken down to pull out the data on older adults, people above 65? I know that's it's a broad when we're talking about need, but is that going to happen? Do you know?
I'm sure it's possible. I'm not personally directly involved in that, but I can find out. Dissecting the MHSDS by age is the easiest thing to do, I think. So I would be surprised if we couldn't do it.
Right. Thank you very much. Well, this has been an incredible webinar, and I think we've all learned a lot, and congratulations to all of our speakers for that canter through a very complex topic, but clearly the passion and the enthusiasm to making sure that the needs of older adults with complex emotional needs are met. And that message about it's not about focusing on the diagnosis, but rather focusing on the need. And somebody said, well, what if you want a diagnosis? Well, obviously, if the person wants to have a diagnosis and they meet the criteria, then you would make the diagnosis. But it's that whole focus on need. And I hope that you will have heard something in this webinar that you can take away and discuss with colleagues, so that locally you can make sure that older people will be able to access an appropriate form of service that will be able to meet their needs. The recording is going to be on the Futures page in 24 hours. And the guidance that Dr. Lord and Dr. Dykes referred to is on the Futures page now, so you can go and get it and download it. Attached to it is a huge wealth of papers. There's a very detailed appendix where you can get lots of examples, and also a link to references. So it's all there and all downloadable. So, I hope that this has really got you all thinking. As I think Tash challenged us to say, we need to start now if you haven't already. And if you've started, then people like Tash and Catherine and the national team are all here to support you going forward. So thank you, everybody, for coming to this webinar. And I do hope that it will really make a difference on the ground locally to you all. So thanks for the team also who've managed the webinar so brilliantly. So thank you very much. And I think that's the end now. Thank you.